Hello, this is Ken Stoltzfus. This video lecture is for Psychology 412, Clinical Psychology. Tonight we're going to be talking about assessment and specifically about the clinical interview. So there are four different methods of psychological assessment. One would be behavioral observation. Sometimes if we work with someone and we get to observe their behavior as it's happening, that helps us to assess the client. That helps us to understand what's happening with them. Another method is psychological testing, and you have a class on psychological assessment that covers a lot of information about psychological testing, so I'm not going to cover it in this course. If you haven't had that class yet, you will have it at some point. The third type of assessment, the one we're going to really focus on in today's lecture, is the clinical interview, and this can be structured or unstructured, and we'll talk more about that in a minute. Finally, sometimes we assess people, and of course by assess we mean trying to figure out what's going on and what they need. And sometimes we talk about determining what their diagnosis is. Sometimes we use a case history to help us to determine that. Sometimes we don't have the luxury of having a case history. So as I mentioned, we're going to be focusing in today's lecture on the clinical interview, and there are two types, structured and unstructured. A structured clinical interview is a format that's purchased by the psychologist or the organization that he or she works for. So this is a pre-made format for the clinical interview. One example of this would be the structured clinical interview for DSM-5 or the SCID-5. If you look that up online, I think you can get a sample of it. You can see some of the questions that they used. Maybe the better term for this would be semi-structured, because the psychologist still retains control of the interview and they're not bound by or limited to the questions on the structured interview. So they always have the right to ask additional questions, but the interview format that they've purchased gives them a guideline to follow. What's more common, in my experience at least, would be an unstructured clinical interview, which really just means that the psychologist talks with the client or questions the client. Now, many organizations have their own format for the interview, and this leads to some structure, but even without this, psychologists still tend to have an internal structure for the interview. And this structure is guided by wisdom and experience, and sometimes we talk about that as sort of clinical judgment or practice wisdom. After you've done this for a while, you kind of know what kinds of questions you need to ask, and as the client answers those questions, you kind of know how to follow up with the client. And so most psychologists that I've met tend to just sit down and talk with their clients and try to find out what brought you here, what are the symptoms you're experiencing, how's that affecting your life, that sort of thing. When we think about the interviewing skills that we need to be able to do an assessment well, we need a balance of closed and open-ended questions. And so a closed-ended question would be something like, how old are you? Where do you live? Important information, right? What's your job? Are you married? Those kinds of things. That gives us a yes or no answer, or if it's not a yes or no, it gives us a discrete, concrete piece of information. I live on Kretengosgatve, or I'm married to so-and-so. Open-ended questions would be things like, okay, Mr. Jones, you've described feeling sad most of the time. How does that affect your life? How do you feel when you're having one of these days when you're very sad? What does your wife think about the sadness that you're feeling, and how does it affect your life at home? And you see how those are open questions, because the client's going to tell us a story in response to those questions, or at least that's what we're hoping will happen. Some clients are less verbal than others. Another interviewing skill is active listening, and I think you've learned about that already probably in a number of classes, but what we're talking about is paraphrasing back or reflecting back to the client what we heard them say. And so if the client tells us that they've really felt down and that they're not taking pleasure in the things they used to take pleasure in, and that they're really just sad most of the time, we might reflect back and say, so what I hear you saying is that most of the time you're really sad and you're not sure why. And we're kind of giving that information back to them, and then usually that will prompt them to go further, and they'll say, yeah, and it's really, it's affecting me at work, and I'm really, I'm not getting along with my wife and my kids the way I used to. And that active listening tends to kind of take the conversation further and deeper. It helps us learn more about the client. The other thing it does is it tends to make the client feel very heard. They tend to come to see somebody who's doing active listening with them as somebody who's on their side, who cares about them, who's really listening well to them. Another thing that's really important is listening for emotion as well as information, because sometimes the client will be telling us something, but there's a deeper meaning there. And so they might be telling us about a situation at work, but we might notice that they're getting very sad, but that their story is sort of about, a routine day at work, but that there's this sadness there. And we might want to ask them, well, it seems like you're really sad when you're talking about work and what happens there. Can you explain that to me? Or can you tell me more about that? Another skill that we want to have is empathetic response. Sometimes we get so focused, and especially new clinicians, new clinical psychologists, get so focused on collecting information, trying to make a diagnosis, that they forget to listen empathically, to be empathetic with the client. And so if the client's telling us about how their drinking has caused their marriage to break up and they really miss their spouse and their kids and they don't know what's going to become of their life, we don't want to just be writing down that their wife and children are estranged from them because of their drinking, but we usually want to say something like, wow, that must be really hard for you. I'm sorry to hear that's been happening for you. And that shows that we've sort of put ourselves in the client's shoes a little bit, and we're thinking about how that would feel for them. We can never totally understand what another person's going through the way that they're experiencing it, but we can show a willingness to enter into that with them, and that's what we're thinking about when we're talking about responding empathetically. We also want to think about body language, and when I teach this class in a face-to-face setting, I often do an exercise where I have two different students play the role of clients, and with the first one I slouch in my chair and look bored, and I ask the exact same questions both times, but the second time I lean forward a little bit, I sit up straight, I pay attention to the client, I do the active listening. But one of the things that we find is just that body language. In addition to whatever I say and the questions I ask, the way that I present myself makes a difference. And even the arrangement of our physical space. What we don't want is a lot of barriers between us and the client. We don't want the clinical psychologist on a big, comfortable chair and the client on a small, hard chair kind of sitting beneath us. We want to have our space set up in a way that sort of illustrates or symbolizes that we're equal with the client. We're not sitting behind a desk, because that's usually an authority symbol. In the U.S. at least, when you are in school and you get called down to see the principal and you're in trouble, the principal is sitting behind a desk and you have to stand in front of the desk, and you sort of know you're in trouble then. So we want to make sure that we're not sending those kind of messages with how our physical space is arranged. So that also kind of falls under the category of interviewing skills. I want to give you an overview of some of the things we do in a typical clinical interview. And the next few slides contain a lot of categories that have some closed-ended questions. But I want to make sure that I say right now that these categories, they represent domains and topics we need to explore, and that exploration always occurs best using open-ended questions in addition to the closed. So, I'm gonna give some examples, like asking about physical health. Well, that's kind of a concrete, do you have any medical diagnoses? Yes or no. But we always want to explore that further, and I'm not going to say that with each category we come to, but I'm going to say it now, just that we're not just going to ask this closed-ended question and move on, but we're going to talk again with the client about things like, oh, so you've been diagnosed with multiple sclerosis. How does that affect your life? What's that like for you? And again, we're using those open-ended questions in addition to the closed-ended questions. We want to have a balance of those two. One of the things that comes up when I teach this class face-to-face is that people sometimes will say, do I really have to ask about all these different questions or categories every time that I meet with a client for the first time? No, you don't have to. You're going to use different questions depending on the client's needs. Sometimes your agency will have a form for you to fill out. We really want to focus most of all on hearing the client's story, not just on filling out a form or asking a certain number of questions. The other thing I'd mention is that the items on these next few slides, for some places, they might represent intake as well as assessment questions. So some places I've worked, there would be somebody else who would meet with the client for what's called an intake before I meet with them for the assessment. And so the intake might take care of some things like demographic information, relationship status, address, that sort of thing. So I may not always have to ask some of those more basic questions. There may be a clerical staff person or an entry-level staff person who would take care of some of the more basic questions, depending on how the roles are arranged in that particular organization. So some of the assessment domains or categories that we want to think about. The first one is demographic information. This would be questions like, where do you live? Are you married? Do you have a job? Those sorts of things. We next want to ask the presenting problem, and a lot of times I try to ask that pretty open-endedly. I'll say something like, so what brings you here today, or how can I help you? And usually then we start to get a story about, well, I've got a good job and I'm really happy with my life, but, or at least I was really happy with my life, but a few months ago I just started feeling sad and down all the time. And, so then we're trying to think, well, this might be somebody who's dealing with some form of depression. Another thing we ask about is physical health, and this is important because there are sometimes physical ailments or physical illnesses that have mental health symptoms. For instance, you might have had a traumatic brain injury, you might have hit your head in a car accident. That can cause behavioral changes. So we want to ask about physical health. We also want to ask about that because sometimes our mental health our mental illnesses have physical symptoms. Somebody who is anxious may have a nauseated feeling in their stomach or a racing heart rate, and so we want to ask about that too. We want to ask about family of origin information. A lot of times I try to find out some information about who the person lives with. Do they live with family? Do they live with friends? Do they live by themselves? What was their family of origin like? Did they have a good relationship with their mother and father growing up? Was their family intact, or were their parents divorced? Did they live with somebody besides their parents growing up? Were they in a foster care system or in an orphanage? Those are all kinds of things we'd want to ask about in a lot of situations. Cultural information, here in the U.S., a lot of white middle-class Americans who I worked with would just say, well, I don't have a culture, I'm American. And they kind of saw culture as people who were in minority groups, but that's not always the case. There's sometimes that people identify strongly with a culture. Sometimes people come from cultures different than what we can tell just by looking at them. And so it's always good to ask about that. And I was thinking about when I lived in Klaipeda, there were still schools for people who are Russian speaking, and so it would be good to know if a client comes from a Russian family where the children attend a school that is Russian speakers, and they kind of live in a situation where they might speak Russian at home, and they might be very different from the Lithuanian family we work with that goes to a different school and speaks a different language at home. And so even though they're citizens of the same country, those cultural differences could be significant, and they could have different experiences of living in Lithuania. That they might feel more or less happy there depending on how well received they feel that their culture is. We might also want to ask about spirituality and religion. In fact, in some situations now in the U.S., it's really recommended or even required that we do this. For instance, hospital admissions, we have to ask if somebody has a religious belief, if they believe in God, and if they'd like to have a pastor or a clergy person involved in their treatment. And so some people will say, no, that's not really important to me, but for some people, their religious beliefs are the most important thing about them. And so we want to make sure that we at least check on that with them, that we ask them if they have any beliefs that are important to them. And if they do have those beliefs, we might want to find out how they'd like those to be involved in their treatment, if at all. So for example, sometimes people have said, well, I'd really love to have my pastor or my priest come to counseling with me, come to treatment with me, just so they can understand what I'm going through. And maybe they don't come every time, but maybe they just come once to kind of find out more about what the client's going through. We usually want to try to find out if the client's been abused, and if they have been, in the U.S., if the client's a child, we have to report that. Or if the client is somebody who is not able to act on their own behalf. So if they're an older adult who has reached a point where maybe there's another person acting on their behalf, they're not maybe at a point where they can do that, whether because of cognitive functioning or because of health issues. If the client isn't capable of protecting themselves, acting on their own behalf, then in many places we have to report if they're being abused. Now, somebody who is of sound mind and able-bodied who's being abused, who's an adult, then it's their choice. For instance, I once worked with a woman who had been raped, and she knew the person who raped her, and she did not want to report it. And as much as I wanted her to report it, I couldn't report it for her because she was of sound mind and able-bodied, and she was able to make that decision about what she wanted to do in that situation. So it's different when we're working with a vulnerable group like children or people who have aged to a point where they're not able to care for themselves and act in their own best interest. A few other domains we'd want to ask about: relationships. We want to ask about, again, who are their close relationships. So this could be romantic, this could be family, these could be friends, but who are the people that are important in their life? Also, sometimes it's good to ask who they live with if we haven't done that already. This next one is a little bit awkward, so I usually save it until I've talked to the client about some other things. But we often want to find out, is the client sexually active, and you know, what role does that play in their life? And for some people, they might just say, well, I'm married and I have a spouse, and that's it. Other people, we might find out that they've been drinking heavily and they've been cheating on their spouse while they're drinking, and that's causing a lot of problems. And sometimes that doesn't come up unless we ask about it. So we want to be sure that we are open to asking about that if necessary and if it seems like it's warranted by the situation. Finally, we want to ask about mental health and substance abuse history. Has the person ever been diagnosed with a mental health and/or substance abuse issue or problem? And a couple reasons we ask about this. One, it's really helpful to know if this is the third or fourth time they've been in treatment for depression. There's going to be records someplace. We may be able to get those records. Substance abuse, we always ask about that. Even if the person hasn't been diagnosed, we ask about their history, because it's really, really hard to diagnose somebody if they're actively using substances. People often hear and see things that aren't real when they're using substances. If they're not using substances, we start thinking about a psychotic disorder. If we know that they're seeing those things when they're high or drunk, it's a totally different situation. So we want to really have some of that background information about mental health and substance abuse. We also want to ask about suicidal or homicidal ideation. Of course, suicidal ideation would be ideas about hurting oneself. Homicidal would be ideas about hurting or killing someone else. And so usually sometime in the assessment, we ask, is the person feeling suicidal or homicidal? And we usually ask that by saying something like, do you feel or have you ever felt that you might hurt yourself or someone else? If the person says yes, we usually ask them if they're willing to make and sign an agreement. We call that a contract or a safety contract, stating that they won't hurt themselves or anyone else if it's more of a homicidal ideation. There's been some research on this, and the research says that these signed contracts don't necessarily change what someone's going to do, but this is seen as kind of doing your due diligence. If somebody makes a comment like this, we want to do our best to keep them safe or to keep the other people involved safe. And so asking them to sign a contract is a good place to start. It shows that we've tried to get the person to commit to not doing whatever it is that they're thinking about. The next thing we want to do is we want to assess their plan and assess their means to commit the plan, figure out whether they have access to the means to commit the plan, and the lethality of the plan. So if the person says, and I had somebody say this to me one time, she was on a lot of medication, and the medication wasn't anything that if she didn't take it, she was going to die immediately. It was just, it was sort of for her health. She had a variety of health problems, and the medication helped her to stay healthy. And one time she said to me, I'm so down, I just feel like maybe I'll stop taking my medication and just sort of let things go and just, kind of hope that my life ends sooner. Well, I'm concerned about that, but in terms of lethality, if she goes without taking her medicine for a day or two, she's going to be just fine. That's very different than the client who says, I've got a knife in my kitchen drawer at home. I think I'm going to go home and slit my veins with it. That's a lethal plan, and they've got the access to the means to commit the plan. So those are the kinds of things. It doesn't mean that we take the less lethal and the less immediate plan, that we just sort of don't take it seriously. But if there's a plan that really is lethal and the person has access to it and they have the means to commit the plan, that's the kind of thing we really want to figure out a plan before we let them leave the office. One of the other things we do is develop a safety plan, and so usually what we'll do with a client is we'll develop a list of phone numbers of people that they're willing to call if they feel like they're going to break our contract. In the U.S., there are often these places called crisis intervention lines, and I know that in Lithuania there was a helpline that some of our students used to volunteer on, or a suicide prevention line, and so that could also be a part of the safety plan. That if the people that they're going to call aren't available, that they'll call the hotline that's available. We always want to consult with our supervisor because it's really good to have somebody else's opinion. If the supervisor isn't there, or if you are the supervisor or director, I still encourage you to consult with a colleague. Just when we're talking about somebody's life, whether it's a client's or another person's, we want to make sure that we've kind of covered all of our bases and gotten everything done that needs to be done. Having a colleague or a supervisor advise us on what we've done and kind of think with us about what we've done is a good way of making sure we've done our due diligence. Another thing we do in the course of the clinical interview, the assessment by a clinical interview, is the mental status exam. You might have heard of this. This is where we note the client's appearance. We often use words like appropriate, disheveled, inappropriate, etc. We also make a note about the client's alertness. Can the client focus on us? Can they answer your questions? We want to make a note about the client's speech, and we want to talk about their tone. Is their tone appropriate? Are they saying they're happy but they sound really angry and forced? Are they talking really softly or really loudly? Are they talking too much or not enough? That's what we mean by quantity. I want to make a note about their behavior. Is it appropriate, or are they agitated, or are they acting inappropriately in some way? We also want to report on their mood. You know, how does it, we want to ask them, how are you feeling? What's your mood today? And then we want to figure out their affective presentation. So this is our assessment of their mood. Is it congruent with their report? So if the client says they're happy, but they're sitting there and they're frowning, they're wiping away tears, then we'd say their affective presentation is incongruent with the reported mood. We also want to look at their thought process. Is it logical? Or are their thoughts kind of disconnected? Do they have the flight of ideas where they've got a lot of different ideas sort of coming and going? Are they tangential where they kind of go off on tangents and talk about things that are sort of not related to each other? Do they have loose associations? Are they not able to associate concepts with logical other concepts that relate to them? Those are some of the different things we might see and note in terms of thought process. Finally, we usually want to do a short memory test. We might give them 3 items: a pencil, a chair, and a table. And then we're going to ask them to repeat those back to us immediately, and then we're going to ask them again in 5 minutes. We also want to find out if they're oriented to person, place, and time, so that they know who they are, where they are, and what time it is. It doesn't have to be the exact time of the day, but at least the date. And if they are, then we say that they're oriented ×3, or oriented to person, place, and time. We want to think a little bit about their judgment. Are they showing good judgment? You know, sometimes in the presenting problem, they'll tell us that they've lost their job because they beat up their boss and their boss's son at the office. Not very good judgment there. And so we want to just get a sense of, is this client showing good, appropriate judgment or not? We also want to think a little bit about thought content and make a note about this. You know, are their thoughts logical, or are they delusional? Delusional would be false beliefs. One fairly common delusion is that somebody's Jesus. You know, so somebody that believes that they're Jesus, that's a delusion. Paranoid would be somebody who believes that there's some sort of a conspiracy to harm them. This often goes along with schizophrenia, with one subtype of schizophrenia. Phobic, do they have a fear of something? This would be more of less of a paranoid fear and more of a fear of a specific thing or situation. So that could be spiders, or it could be fear of leaving the house, that sort of thing. Are they having hallucinations? You know, are they seeing, hearing, smelling, tasting, feeling something that's not there? That'd be a hallucination. And then fixations or perseverations, we see this with people on the autism spectrum. This is where they just get stuck on one thing. I worked with a boy one time who perseverated on clocks. He was just fascinated with clocks. He wanted clocks around him all the time. He was always asking his mom what time it was, those kinds of things. That getting kind of stuck on something would be a fixation or perseveration. Okay, so those are some of the things that we do and ask about during the clinical interview. Hopefully this is helpful and gives you a little bit more of a picture of what a clinical psychologist does when they're assessing someone. And I hope you're having a good week, and I will talk to you next week. Bye now.